Hello, and welcome back to the series of talks on how to use study design to control for the effects of unmeasured covariates. In this talk, I'll look at the use of self-matched designs, and I'll use as an example the most commonly implemented form of the most commonly used self-matched design, the case crossover study.
Here is the causal diagram for unmeasured covariates that threaten to become unmeasured confounders. The unmeasured characteristic U affects the probability distributions of treatments and of disease outcomes. The result can be an observed association between treatments and disease, even when treatments have no direct influence on disease. Because the covariate is unknown, the empirical correlation between treatment and disease may look like it's driven by a causal effect. In the first talk, we saw that randomization blocked the correlation between treatment and the unmeasured characteristic through experimental assignment of treatment. Self-matching compares different treatments at different times within individuals. All the characteristics that do not vary with time are therefore constant within persons and cannot be correlated with treatment, so they cannot confound. Celecoxib and naproxen are two treatments for pain. Because naproxen can damage the lining of the stomach, patients with peptic ulcer or a high risk for peptic ulcer and bleeding should not get naproxen. Celecoxib is less risky. No treatment at all is safest. The physician's understanding of the patient's risk affects her choice of therapy. Among treated patients, those with a history of peptic ulcer and bleeding are most likely to get celecoxib because it's safer. But those same at-risk patients will have more ulcer problems in the future, making it look like celecoxib causes ulcer. This is confounding. A self-matched design looks within the experience of each patient for its comparisons. When there is no event, there is no within-person comparison to be made so long as we're looking at relative risk. Having to study only people with events can make self-matched studies very efficient. Let's go back to the study question. Matching on person means that all comparisons are within person, and therefore at a common level of physician perception. The time of observation needs to be sufficiently short that the true risk and the physician perception do not change, unless we're prepared to construct statistical models of time-varying confounders as well as time-varying exposures. The most common implementation of a self-matched design compares the exposure at case occurrence to sampled exposure in the past. As I just mentioned, non-cases drop out when matching is within person. And all the time periods that are not part of case windows or control windows drop out from the analysis too. Here are some definitions of what we've done and a short description of how a so-called case crossover study proceeds. The analysis is driven entirely by those cases in whom exposure in the case window was different from that in the control window. You can do a crude analysis that accounts only for the matching, or, if you have collected information on time-varying characteristics other than treatment exposure, you can do a multivariate analysis as well. Here's a published study of naproxen, celecoxib, and non-treatment for pain. I've copied out the abstract so you can see the key terminology more easily. Notice the use of the term case period, which you'll recognize as being what we've called the case window, the control period, and the use of conditional logistic regression to obtain the estimates. Here's the main table of results. Let's see how it maps on to the analytic table I just showed you. 413 people were exposed during their own case window, but not during the control window. 232 people were exposed during their control window, but not their case window. Taking the ratio of these so-called discordant pairs, we get the crude rate ratio that the authors report. Comparing the crude and adjusted rate ratios, we see that the adjusted ratios are regularly smaller, indicating that the multivariate analysis is controlled for some further confounding by measured time-varying characteristics. That is to say, at times when these patients were treated for pain, they were at higher risk for hospitalization for gastric bleeding for reasons other than the drugs they took. This covariation of risk factors somewhat inflates the crude result and is adjusted in the multivariate result. Notice that as expected, the relative risk associated with the use of naproxen versus no treatment is somewhat higher than that for celecoxib. In sum, Self-matched studies compare exposure at the time of an outcome event to the probability of exposure in the same person. The probability is calculated from the individual's own history, assuming that the null hypothesis of no effect of exposure on risk of outcome. Unmeasured covariates that do not vary over time within person do not confound the estimate of relative risk. Self-matched studies work well for intermittent exposures whose associated risks rise and fall quickly. Self-matched studies give mathematical meaning to the question you might well hear from your doctor. Were you doing anything unusual just before you got sick?
In the next talk, I'll look at how to use proxy variables to control for the effects of unmeasured covariates. Thank you for your attention.